colleagues. It is my pleasure to introduce a short presentation about COVID-19 and the cardiovascular complications. As we know, many patients with coronavirus have underlying cardiovascular disease or develop acute cardiovascular injury during the course of illness. And a large study published in Chinese center with a data about more than 44,000 confirmed cases of COVID-19 infection reported a mortality reaches about 2.3%. And the most common comorbidity in patients who died were hypertension, diabetes, elderly, the age above 70 years of old, and the presence of cardiovascular disease. Also, the most common cause of death is acute respiratory failure, followed by acute respiratory failure and acute heart failure, and followed by myocarditis and myocardial damage. The most common cardiovascular complications reported by coronavirus is acute coronary syndrome, left ventricular failure, myocarditis, and heart failure and arrhythmia. Myocarditis, the exact incidence of myocarditis related to the COVID-19 is currently unknown. However, the presence of elevated biomarkers, new onset heart failure symptoms, the presence of cardiac arrhythmia in patients with confirmed COVID-19 infection may rise the possibility of acute myocarditis. Acute heart failure and cardiogenic shock is reported in one series of COVID-19 patients. The incidence was 23% and was significantly higher among non-survivors. And the precipitating factors for acute heart failure and the cardiogenic shock in patients with COVID infection were multiple precipitating etiologies like acute coronary syndrome, the presence of fulminant myocarditis, stress-induced cardiomyopathy, and the presence of cardiac arrhythmia. The cardiac arrhythmia reported in one series including 138 patients with confirmed COVID. The incidence was higher among those admitted to the ICU infection compared with none treated in the ICU, and the cardiac arrhythmia were common in patients with mild and moderate cases, not severe cases. Severe cases may end into acute respiratory failure and acute heart failure. There is a lot of possible mechanisms contributing to the pathogenesis of cardiovascular complications in patients with COVID-19 infection. One of them is the direct myocardial injury by the virus itself, because the virus binds to the ACE2 receptors, which is highly expressed in the heart and the lung. The second possibility may be related to systemic inflammation. The third possibility, impairment of the oxygen demand and supply ratio. Also, inflammation may cause plaque rupture and coronary thrombosis. Antiviral drugs, as I will show later, may contribute to the pathogenesis of cardiovascular complications, and electrolyte disturbance, hypokalemia in patients with COVID-19 infection may predispose to tachyarrhythmia. For the management implications as regard the caregivers, it is our utmost responsibility to protect ourselves from getting infected while managing these patients. Therefore, all healthcare personnel engaged in the case of COVID-19 patients must observe necessary precautions at all times. And all of them should be trained in using the personal protective equipments in accordance to the existing practice guidelines. Also, the hospital, there must be hospital protocols for rapid diagnosis, triage, isolation, and the management of COVID-19 patients with cardiovascular complications. For unnecessary diagnostic tests must be avoided, like investigations like troponin or even echocardiography. I will show the guidelines of European of the American College of Cardiology. For the precautions, we have to use hand washing, careful hand washing, gloves, isolation gown, surgical masks, or even N95 masks, especially if we suspect special droplet infection or airborne infection, like in special situations where tracheal aspirations is needed, or even during cardiac catheterization. Face shield also, especially in special situations with droplet infection or airborne infection, and shoe cover. All these precautions must be done accurately. And the American College of Cardiology and the American Society of Echocardiography recommendation put an algorithm for patients doing echocardiography and for patients already proved COVID-19 infection. It's better if echo is not necessary, it's better to avoid it. But if echocardiography is necessary, we have to follow all the precautions done, and they recommend it's better not to do or to limit exposure for critically ill patients, immunocompromised, or even during pregnancy. And the patients elderly above the age of 60, we have to limit exposure to those group of patients when we do echocardiography. Also, patients presenting with STEMI with potential risk of COVID-19 infection, we may have to consider risk-benefit ratio for primary PCI versus fibrinolysis, and the American College of Cardiology and the American Heart Association recommendation, it is better to avoid primary PCI and give the patient thrombolytic therapy, unless in special patients with complicated STEMI, we can go to cath lab with special precautions, and they put also algorithm for management of these patients. Also, for patients with non-STEMI, presenting with non-STEMI, it's better to at first to risk stratify patients with non-STEMI, and if the risk is low or moderate, we can manage COVID patients with non-STEMI with medical treatment and transfer to a specialized hospital for isolation, or if the high-risk patients by Grace score, we can go for cath lab, and after PCI transfer the patient to isolation center. As regards the outpatient clinics and the elective procedures, we have to give physical and social distance and discuss the potential of spread of virus infection among the physicians and among the attendants in the clinics and the community. So it is appropriate to explore alternative ways for interacting with the patients, such as telephone or Skype or virtual clinics, and avoid hospital visits and postponing elective procedures. Concerning the investigation therapies and risk of cardiac complications, especially in cardiac patients, one of the known adverse cardiac effects of the antiviral drug is dyslipidemia, prolongation of QT syndrome, and this may predispose to arrhythmia, especially in patients infected with COVID and have a structural heart disease. Anti-malarial drugs, which are commonly used in the regimen of treating patients nowadays, the most common adverse effects is the prolongation of QT syndrome, which may predispose to cardiac arrhythmia. The use of ACE inhibitors and ARBs in patients, hypertensive patients treated by these drugs and develop COVID infection, theoretically, as I mentioned before, that COVID virus attack ACE2 receptors, and with the use of ACE inhibitors and or ARBs, there is upregulation of the ACE2 receptor, and theoretically this may aggravate the course of early infection of the disease, aggravate the early course of the disease, and end by complication. This is a theoretical. However, the FDA and the American College of Cardiology recommendation that patients already receiving ACE inhibitors or ARBs for hypertension should continue these drugs, because there is no proven evidence or no solid evidence for adverse effects of these drugs during the COVID infection era. I wish good health for you and all people, and I hope that these circumstances will pass rapidly and return back to face-to-face meeting, and stay home, stay safe. Thank you.